Dr. Gregory Thoreson is a board-certified urologist with urology clinics in North Texas. He received his Doctor of Medicine from University of Texas Health Science Center in San Antonio and completed his residency at the University of Texas Southwestern Medical Center in Dallas. Dr. Thoreson specializes in treating a wide variety of urologic conditions in both male and female patients, including kidney stones, prostate cancer, enlarged prostate, urinary incontinence, erectile dysfunction, and low testosterone. We have a lot of great content to cover tonight, so Dr. Thoreson, I'm going to turn it over to you to get us started.
Thank you, Abraham. So just briefly, in terms of what we're going to be talking about tonight, we're going to be reviewing prostate cancer and just doing a high-level overview. We're going to go into some of the treatment options as well, too. And specifically, we're going to get into radiation therapy and some of the benefits associated with the hydrogel rectal spacer. So we'll go ahead and get started here. So, just off the bat, in terms of what the prostate is, it's a reproductive organ, and it sits at the base of the pelvis. It lies in between the bladder and the urethra, and it's roughly a walnut-sized gland. And it essentially encases the urethra, so it surrounds the urethra and essentially becomes the prostatic urethra. And it supplies the fluid that transports sperm during ejaculation. So the question that we get often in the office is, what's the difference between benign enlargement of the prostate as well as cancerous growth of the prostate? So as men age, the prostate grows in size and presses against the urethra and can cause some bothersome symptoms. So that's going to be benign prostatic hyperplasia. Specifically, this is not cancer, but it's important to know that it may coexist with cancer. So it's important that you keep these two things in your differential as you're talking about this. There are times when advanced prostate cancer actually does show up like benign prostatic hyperplasia with obstructive urinary symptoms. So it's important that you keep both of these within your framework as you're evaluating a patient for this. So similar to symptoms of BPH, prostate cancer could include things like weak urinary flow. We do often check PSA values in this situation, and it helps determine the difference between the two, although it's not always specific for one versus the other. So sometimes it does require further investigation. So, we talk about prostate cancer as being one of the most common cancers in men. We say roughly 1 in 8 men are diagnosed with prostate cancer. And as you look here, it does talk about the 5-year survival rates as being excellent. That plays largely in part to the fact that prostate cancer generally is a pretty slow-growing disease, especially in the early stages. So as we talk about prostate cancer, it's important to kind of zoom out and look at what the rate is in the U.S. population. So, we discussed that it's roughly about 270,000 new cases every year. And unfortunately, about 34,000 to 35,000 men will die of prostate cancer every year in the United States. For regional or localized prostate cancer, most men do not experience any adverse outcomes relating to death in a 5-year time period. And when you combine all stages, relatively men do quite well with that. Again, speaking about the latency of prostate cancer, generally the studies that show the most impactful change with regards to treatment lasted, somewhere 20 plus years. So it generally is a slow-growing disease. So when we start talking about risk factors for prostate cancer, as we age, that risk for prostate cancer certainly increases over time. And when you start looking at men who are over 65, about half of all of our prostate cancer cases are found in this patient population. So we also talk about the inherited patterns associated with prostate cancer. Having a first-degree relative greatly increases your risk of having prostate cancer yourself. And when we start talking about race and ethnicity, it's unfortunate, but it does appear to be true, and it has been true for quite some time, that if you have African-American heritage, you are at increased risk of developing prostate cancer, as well as lethal forms of prostate cancer. And these are areas of active investigation at this time. One of the other things that gets discussed is that men of Latino or Hispanic heritage have slightly less probability of receiving treatment for their prostate cancer. And then we start talking about risk factors for it. There are some studies that suggest that chemical exposure, especially men who have served in military service, sometimes are at an increased risk for the development of prostate cancer. And then, we are, actively investigating whether or not prostatitis or chronic inflammation from infectious agents may also increase the risk of prostate cancer as well, too. So when we start talking about screening for prostate cancer, there's a number of guidelines out there. The one that's displayed here tonight would be from the American Cancer Society, which is a great resource. When they start talking about when to screen for prostate cancer, men at average risk for the development of prostate cancer are generally recommended to start screening at the age of 50. But for men who are at a higher chance of developing prostate cancer, we sometimes introduce a baseline PSA test either at the age of 45 or 40, depending on how high of a risk it is for you to develop prostate cancer over the course of your lifetime. A single PSA value goes a long ways. And, if you risk stratify men, even at the age of 40, you can wind up potentially identifying prostate cancer kind of as it starts sometimes and altering the course of the outcome that would have taken place from that type of prostate cancer. So when we start talking about screening, overwhelmingly, the way that we do this is with a blood-based test called a prostate-specific antigen. It does check for prostate-related matters, but unfortunately, it's not specific for prostate cancer. So oftentimes, we have to combine that with some other tests to properly identify not just any kind of cancer, but what we're really looking for are clinically significant prostate cancers. So, those are the prostate cancers that were essentially destined to harm somebody and potentially cause a premature death relating to prostate cancer. Another benchmark for screening for prostate cancer would be the digital rectal examination. So we have had some tools that are increasingly useful in the detection of prostate cancer. So the digital rectal examination still is a part of the diagnostic tool set, but it's not as foundational as it once was from a historical standpoint, especially predating things like blood-based markers that we have now. We also talk about doing genetic testing as well, too, where we can identify men who are at higher risk of the development of prostate cancer based on inherited traits. And then when we start talking about an MRI or a transrectal ultrasound, those are great for visualization of the prostate and assessing certain characteristics of the prostate that may be concerning for prostate cancer. And then some of the other ways to screen for prostate cancer would be through, just taking a very good history and physical on a patient. And, sometimes you can identify that just with that alone. When we start talking about the diagnosis of prostate cancer, and it's true for not just prostate cancer, but many, if not all cancers, where we do indeed need tissue to obtain that diagnosis. The way in which that is done is by performing a prostate biopsy. There's two different approaches that we could take. There's a transrectal approach, so that would be through the rectum, or through the skin, so that's a transperineal approach. The transperineal approach is pretty widely adopted in European cohorts. Here in the United States, it hasn't really achieved widespread adoption at this point in time, but it's an active area of investigation at this time. And based on the pathology report from that biopsy, certain determinations can be made, and that would be whether or not prostate cancer indeed was present or was absent. And having negative prostate biopsy results, unfortunately, can't guarantee that there was no prostate cancer present. It just means that it was not detected at the time of the prostate biopsy. So when we start talking about prostate cancer, there's a wide variation in terms of how they behave, and that also determines what type of treatment we pursue. So one of the most succinct ways to talk about cancer, and this is going to be true for all cancers, not just prostate cancer, but we talk about T&M staging, and we'll get into that a little bit more in the next slide. But this is the way in which, kind of amongst the oncology communities, we can talk about, how the presentation or kind of current state of your cancer health currently is. The other thing that's specific for prostate cancer would be the Gleason score, and we'll kind of get into some of the Gleason grade grouping as well too. When we start talking about some of the other things that complement this, your baseline PSA is a very important benchmark for kind of knowing where we stand on things. And then also your imaging is critically important for knowing where we stand on things. We do use genomic testing. We do talk about the volume of tumor that's present, as well as clinical exam findings, specifically the digital rectal examination. So, as mentioned before, the T&M staging, it's an acronym, and it stands for tumor, nodes, and metastases. And we also have kind of a grouping as well too, with staging of 0 through 4. And that kind of lets all of us kind of talk freely about where we stand on things. Some of the later stages of prostate cancer, we'll also talk about whether or not they are hormone sensitive or hormone refractory. And that's not really a part of our talk tonight, but that's another kind of thing that we talk about sometimes with prostate cancer in later stages. When we start talking about the Gleason grouping, we've kind of shifted to a term called Gleason grade grouping now. So it goes 1 through 5. And as you can see on the slide, you'll see low risk, intermediate risk, and high risk prostate cancer. Within those groupings, you'll kind of go with, Gleason grade group 1 through 5 on that. And you can kind of see how they're broken down there. That really draws in the distinction between Gleason 7 prostate cancer, where there is a difference in the behavior of Gleason pattern 3+4 versus Gleason pattern 4+3 in terms of the relative frequency of the presence of that specific Gleason score. So when we start talking about treatment options, we're going to go through kind of the beginning to end in terms of how we treat organ-confined prostate cancer. Some of the other treatments will also include things like hormone therapy, chemotherapy, cryotherapy, HIFU, immunotherapy, and targeted therapy. But for tonight, we're just going to be focusing mainly on the kind of cornerstone types of treatments that we do. So that would be active surveillance, surgery, as well as radiation therapy. We're going to get into those details here in just a little bit. So active surveillance, what is it? When did it start? Where did it start? So this is a term that we use for essentially closely monitoring someone's prostate cancer. It's generally widely accepted for low-risk prostate cancer, where routinely we will observe that in certain institutions in certain parts of the world where prostate cancer is managed differently. Active surveillance is used for intermediate, and rarely would it ever be used for high-grade prostate cancer. But there's an increasing trend towards the use of active surveillance for intermediate risk prostate cancer, and that started in areas outside of the U.S. As well as within the U.S., but certain healthcare systems are kind of more favorable or more well-suited for something like active surveillance. So that's why it's been kind of adopted by certain parts of the world. And through that adoption, we've been able to kind of go back and look through their data, because they've done an excellent job of showing their outcomes, and men do well with active surveillance in the right situations. Obviously, this requires, quite a bit of follow-up and, successive evaluations and sometimes repeat evaluations of where you stand. And sometimes, in the office, we talk about how when we're dealing with prostate cancer, especially before we pursue treatment, it is somewhat of a moving target. So active surveillance isn't necessarily a permanent destination where you stay, but it's an area in which we can kind of proceed in a holding pattern where, we safely watch your prostate cancer and, essentially make sure that when you cross a threshold that is determined between both the patient and the physician, as far as where you draw the line in the sand, you would ultimately pursue treatment if you indeed did proceed into a kind of more aggressive form of your prostate cancer. So when we start talking about surgery, this is the one that requires, I feel like, quite a bit of discussion with the patient regarding, the side effect profile associated with this. Some of the most dreaded complications from a patient's perspective would be the loss of control of the flow of urine. Specifically, we talk about stress urinary incontinence. So that's the leakage of urine when you cough, laugh, or lift heavy things. And then we also know about impotence. So that's the loss of erectile function that happens with surgery. Luckily, surgical techniques have improved over time, and these outcomes have also improved over time. And we're continuing to push the envelope in terms of what we can offer our patients, specifically with regards to trying to mitigate this side effect profile. But ultimately, if we do determine that surgery is the best fit or a good fit for you, these are some of the kind of commonly encountered side effects associated with surgery. And again, we do try to introduce as many maneuvers as possible to try to reduce these risks. One of the benefits associated with surgery is that, down the road, if you ever needed to, something like radiation therapy would still be on the table for discussion, and oftentimes is well suited in the event that a cure is not obtained with surgery alone. And as we start talking about radiation therapy and the timing of that versus surgery, the reverse isn't necessarily true, where if we pursue something like radiation therapy, although surgery could be pursued afterwards, this side effect profile that we are talking about tonight would be dramatically accentuated. So we would see higher rates of urinary incontinence as well as sexual dysfunction in those situations. And one of the other things that we talk about for the side effect profile is this loss of fertility. And that's kind of one of those givens when we were talking about, the complete removal of a reproductive organ. So as we talk about surgery, there are certain institutions that still do offer open radical prostatectomies. They're not as common here in the United States. Most approaches are a laparoscopic approach, specifically a robot-assisted laparoscopic approach. And then that technology is kind of evolving over time as well, too. So we've seen some evolutions in that surgery itself, and it continually is improving over time. So men do achieve some of the best outcomes that we have seen to date with these approaches. So that's surgery in a nutshell. So when we start talking about radiation therapy, especially here in our community, most often it is external beam radiation therapy, or EBRT. And that's also what we're going to be talking about later with regards to some of the ways that we can reduce the side effect profile associated with this. And the way it works is that there are high energy radiation beams that are directed towards the prostate, and they are essentially kind of rotated in different portions of the body, but all focusing on the prostate. And through that rotation, you can reduce the side effect profile associated with the treatment for prostate cancer. And this does not require general anesthesia, which is different than what you would see with surgery. There's no overnight hospital stay, and it's a non-invasive approach. As you start looking at your treatment options, it's important that you discuss with your surgeon and your radiation oncologist what is the best fit for you. And although this does have some very attractive features associated with it, it is kind of a long process that can take a period of time on the order of weeks, depending on the schedule of radiation therapy that you choose with your radiation oncologist. When we start talking about the side effect profile, there are some similarities. Obviously, we're working on the same organ, and it is a reproductive organ that is smack in the middle of the urinary system. So this side effect profile is shared between both surgery and radiation therapy. But as you look at the details between the two, there are some relative advantages associated with, say, radiation therapy as well as surgery, depending on which side effect profile you're talking about. But specifically for radiation therapy, there's incontinence that we see sometimes. There's also sometimes obstructive urinary symptoms that could take place in the short term and potentially in the long term as well too. But that's not as common, luckily. There is some sexual dysfunction that takes place, as well as occasionally bowel dysfunction, and we'll kind of get into that a little bit more here at the end. One of the other forms of radiation therapy would be brachytherapy. And here in our community, we don't see a high adoption of this, but in certain institutions and certain metroplexes around the United States, you will actually see high rates of brachytherapy performed. These are radioactive seeds that are mechanically placed within the prostate, and they stay embedded within the prostate indefinitely. The radiation therapy has a duration at which it will, essentially kind of exude or emit radiation therapy within the prostate. So it's not a permanent thing where radiation therapy is always emitted from these seeds that are placed, but those seeds do remain in place, and we do not extract them at a later date. The side effect profile is very similar to what we had discussed before with external beam radiation therapy. And like this was stated before, it's not commonly available as compared to external beam radiation therapy. And some of these side effect profiles may be reduced with the introduction of a rectal spacer as well. So one of the things that we wanted to get into the details of tonight would be radiation therapy, specifically in regards to a rectal spacer and kind of what it is and how it provides benefit to the patient. So one of the best ways to kind of think about this is to think about how the radiation therapy is performed. And as we talked about, the rotation of the radiation therapy to the organ of interest, you'll see in this picture here, there's a halo effect of some secondary radiation to adjacent structures to the prostate. Obviously, the red portions are the area where radiation therapy is the most intense, and obviously it's focused on the prostate, but there are some areas around the prostate that do receive some radiation therapy. The rectum is specifically an organ at risk when we start talking about the application of radiation therapy to the prostate because they are so close. The rectal toxicity is a side effect profile specifically relating to diarrhea, pain, bleeding, as well as later symptoms like radiation-induced changes of the rectum. So there was a study that was conducted with the use of rectal spacer, specifically a polyethylene glycol-based hydrogel rectal spacer. And there was a dramatic reduction in the side effect profile associated with radiation therapy when this rectal spacer was used. So, in both the gastrointestinal as well as genitourinary side effect profile, you can see the results here, but there was a dramatic reduction. And the study was kind of designed in a 2-to-1 fashion, favoring standard of care at that time. So, in terms of what this hydrogel spacer is, it's an absorbable polyethylene glycol-based hydrogel rectal spacer. And it's placed in between the prostate and the rectum, and it only rests there temporarily. And it's designed to reduce the radiation dose to the rectum, and thereby reducing the side effects associated with radiation therapy. Specifically, as listed at the bottom of this slide, we do talk about the distance there. They do talk about, the type of material that polyethylene glycol is. And, roughly it's just an outpatient procedure that's generally quite brief. And the spacer will stay in place for roughly 3 to 6 months. And then it is essentially absorbed by the body and released through your urine. So specifically, we talk about fewer bowel complications associated with this, and there was roughly 75% reduction in grade 1 rectal toxicity associated with the use of this rectal spacer. And then there was about a 60% decline in urinary quality of life symptoms associated with the use of the spacer. There's also a pretty substantial reduction in sexual side effects associated with the use of the spacer. And this is used worldwide what they state is that there's roughly 220,000 patients to date that have been treated with this. We use it in our practice, and we have good outcomes here in our practice with this. So, in summary, radiation therapy is an extremely effective form of treatment for prostate cancer. And, unfortunately, there are some side effects associated with it. When we use things like a rectal spacer, it does help improve that side effect profile, making that therapy potentially more attractive for a subset of patients or a certain portion of patients. It's a temporary, gel that stays in place in between the prostate and the rectum, and eventually it does work its way out of the body. But by doing so, you do improve the safety profile associated with the use of radiation therapy. So in terms of next steps, it's important to know what your risk level is. And, part of, my drive to do this talk tonight was just to try to increase awareness associated with prostate cancer. It's unfortunately one of those things where it fell out of favor for a number of years here in the United States and is making a resurgence. But as it stands, it's not really something that is routinely talked about in the community. I kind of wish we did talk about it more, and that's kind of what we're here talking about tonight, honestly. So it is sometimes a patient-driven decision to screen for prostate cancer. So sometimes it's important to bring it up with your doctor if it's something that you think is important to you. It's also important to kind of look at some of the treatment options that are out there for prostate cancer. So in the event that you are indeed diagnosed with it, it's important to kind of know what's out there. So some of the resources here, and these were discussed in the slides tonight, but the American Cancer Society, the Zero Prostate organization, there's a prostate health education network as well too. I also like the Prostate Cancer Foundation. That's a resource that I often kind of point my patients in their direction to, just because that's a really good resource, and it's mostly written by patients when you take a look at their patient brochures that they have. But it's also curated by physicians, so I feel like they do a good job with that. So in terms of the references for tonight's talk, these are the references here. And these are the disclaimers here. All right. And